Good morning, colleagues, and welcome to this morning's Downing Street briefing, which is a technical briefing on the COVID-19 vaccination programme. I'm Jonathan Van Tam, Deputy Chief Medical Officer. I'm joining this morning from a clinical area, and in the room you have Dr. June Rain, Chief Executive Officer of the MHRA, and Professor Wei-Shen Lim, Chair of the JCVI COVID-19 Vaccine Subcommittee. Without further ado, I shall pass to the first of our technical experts, Dr. Rain, to give an update from the perspective of the MHRA. Dr. Rain.
Thank you and good morning. As the UK's independent regulator for all medicines, vaccines and medical devices, our role is to ensure that the public have access to safe and effective vaccines. Your safety is always our top priority. And we've continued to proactively monitor the safety of all COVID-19 vaccines since the rollout began last year. Our regulatory position remains that COVID-19 vaccines available for use in the UK have an overwhelmingly positive benefit-risk balance. You can be confident that COVID-19 vaccines for use in the UK are very effective and acceptably safe. Since the booster doses began to be rolled out in people aged 50 and over from September, we have identified no new safety concerns. Our careful review of the data at the time of approval found that the booster doses are effective. Our ongoing safety monitoring has found the majority of adverse effects to be mild to moderate, relating to reactogenicity such as a sore arm or headache or tiredness. When you're called for your booster dose in the next phase, you can come forward confident that the benefits in preventing serious COVID-19 far outweigh any risks. Turning to younger people aged 16 to 17, our regulatory position remains as when we gave the first approval for use of the Pfizer-BioNTech vaccine in those over the age of 16 in December 2020. That is, that this vaccine is safe and effective in a 2-dose schedule. We've closely monitored the safety of COVID-19 vaccines in individuals under 18. Our review of reports of suspected side effects does not raise any additional safety issues specific to this age group. As is set out in our summary report, there have been a small number of reports of suspected myocarditis, heart inflammation, associated with Pfizer and Moderna vaccines in both the UK and internationally. This is a recognised, very rare potential risk with these two vaccines. We're closely monitoring it, and importantly, now that we have more experience of use in the under 30s in the UK, we are not detecting any increase in risk with the second dose. So our message is to people aged 16 and 17, it's safe to have a second dose of the Pfizer vaccine, and if you're called for your second vaccination, please come forward. And this ensures that you're further protected against COVID-19. Just finally, I'd like to take this chance to thank everyone who has reported suspected side effects associated with COVID-19 vaccines. Please continue to report via our coronavirus yellow card. By reporting, you help improve the safe use of vaccines for everyone, and it helps us as your independent regulator to take action if necessary. Safety is always and continues to be our top priority. Thank you, JVT.
Thank you, June. Colleagues will have an opportunity to ask Dr. Rain any questions they wish at the end of the briefing. I'm turning now to Professor Lim, Wei-Shen, to give us an update from the JCVI, which forms the main part of this briefing. Wei-Shen.
Thank you very much. Today, JCVI is announcing 2 updates to the vaccine program. The first update relates to the booster program. Could I have a first slide, please? Just as a reminder, the current advice in the booster program is that persons aged over 50 years, those adults in a clinical at-risk group, frontline health and social care workers, and close contacts of persons who are immunosuppressed should have a booster vaccine 6 months following completion of their primary course, essentially have a third vaccine dose 6 months after their second dose. Can I have the next slide, please? We're advising today that the booster program is extended to persons aged 40 to 49 years as well. As previously, the booster dose is advised 6 months after the second dose, and either the Pfizer-BioNTech vaccine or the Moderna vaccine can be used as the booster dose, regardless of the type of vaccine received for the first 2 doses in the primary course. I'd like to just mention the dose used for the Moderna booster. The dose used is 50 micrograms, which is half the dose used in the primary course, which was 100 or is 100 micrograms. This use of a lower dose of vaccine for the booster dose is a recognized method of boosting vaccine-induced immunity. It has been used for years and is continuing to be used now in other routine immunization programs, such as the booster doses used against diphtheria, tetanus, and pertussis. This is not an unusual thing to do. A lower dose for the booster dose is a very usual method of boosting the immune system. For the Moderna vaccine, we also know that studies have been done looking at the lower dose or half dose booster dose of Moderna, and after the third dose, which is a booster dose, the immune response is far higher than after the second dose. So we know that this half dose as a booster works very well. The half dose of the booster dose is also expected to be associated with fewer adverse events. In the UK, over 12 million doses of boosters have now been given, and as you've heard from MHRA, no major adverse reactions that are new have been identified following the booster program. In addition, today, the UK Health Security Agency, UKHSA, are publishing data on the effectiveness of the booster dose. And their data show that there has been an increased protection against symptomatic disease following the booster dose in those who have already received it so far. And the protection that's been added is such that there is over 93% protection against symptomatic disease. Whilst we don't yet have data on protection against hospitalization and unfortunately people dying from COVID-19, we can expect the protection to be even higher than that figure of 93% because that's what's happened so far in the vaccine program. So overall, we're advising now that the data tells us the booster dose markedly strengthens existing protection and will extend the duration of that protection against serious disease. We therefore urge people who are eligible for a booster to step up and have your booster and maximize your protection. The second update to give today is about 16 to 17-year-olds. You may remember that in early August, we advised a first dose of the Pfizer-BioNTech vaccine for 16 and 17-year-olds who do not have an underlying health condition that puts them at higher risk from severe COVID-19. We said at the time that we would review the data and anticipate that a second dose may well be advised. Now, that is indeed the case. We have reviewed the recent information regarding the safety and the benefits of a second dose, and we are advising that 16 and 17-year-olds who have had a first dose of the Pfizer-BioNTech vaccine be offered a second dose of the Pfizer-BioNTech vaccine. As a reminder, the first vaccine dose gives a high level of protection against serious disease, and that high level of protection we know lasts for at least 12 to 16 weeks. The second dose, nonetheless, reinforces that protection from the first dose and is important in extending the duration of protection, not just for the winter months and Christmas, but we're also looking into 2022 and beyond. There is a question about the spacing and the timing of the second dose compared to the first dose. We are advising that the second dose is given 12 weeks after the first dose. You may remember that at the very start of the vaccine program in the UK, the JCVI advised that second doses of vaccines be given 12 weeks, which is an extended interval after the first dose. We now have quite a lot of data to show that the extended interval increases the level of protection, and by doing so probably extends the level of protection. We also have emerging data to show that the extended interval between dose 1 and dose 2 also results probably in less adverse reactions. So there are overall benefits in keeping an extended interval between dose 1 and dose 2. Therefore, for 16 and 17-year-olds, we're advising that the second dose is given 12 weeks or more after the first dose. In summary, there are two updates we're giving today. The first is for a booster dose for persons aged 40 to 49 years old, and a second dose of the Pfizer-BioNTech vaccine for 16 to 17-year-olds. Both of these updates are important to maximize our protection against this virus, and I strongly urge anyone who is eligible for these vaccines to come and have those vaccines. Thank you.
Thank you, Wei Shen. I am now just going to make a few overarching remarks to follow our two technical experts before we open for some questions. So I think it is clear that we are now moving at considerable pace with the booster programme. The UK data show so far that in adults aged over 60, after boosting with a messenger RNA vaccine, that's either Pfizer 30 micrograms or Moderna 50 micrograms, as Wei Shen has explained, we're achieving well in excess of 90% protection against symptomatic infection, irrespective of which vaccine people had as their primary course. And on the basis of those figures, I would therefore expect protection against hospitalization and death to be even higher after boosting once we have the data here in the UK. For now, we look at the Israeli data and some key publications there showing that in people aged over 60 in Israel, after a messenger RNA booster and compared with simply having received the first 2 doses of Pfizer, in the case of Israel 3 to 4 weeks apart, they are observing a 10-fold reduction against all COVID infections, an 18.7-fold reduction against hospitalizations, and a 14.7-fold reduction against mortality, and that's on top of the initial course of Pfizer. So I believe, therefore, that if the booster program is successful and with very high uptake, we can massively reduce the worry about hospitalization and death due to COVID at Christmas and for the rest of this winter for literally millions of people. It really is as simple and decisive as that. Now, JCVI is independent and it is thorough. It first showed its independence when it advised on the 12-week interval for vaccines at the beginning of the UK programme. And at the time, it was publicly criticised for doing so by the British Medical Association and the World Health Organization. But the data now show that JCVI was right, and many nations have now followed the UK strategy. So, whilst vaccines have fundamentally changed the course of the pandemic in the UK, and the high uptake of the initial programme has saved countless lives and helped restore our freedoms in an unprecedented way, it is also clear that protection will wane over time, and that is after the first 2 doses of a primary course. And that's especially so in older adults and those with risk conditions. And that explains why we've already made the decisions we've made about the booster programme. But the waning signal, whilst smaller, is also beginning to show in the 40 to 49s. And without boosting, I would not expect it to be static. I would expect it to increase. So JCVI has again acted decisively and recommended that the booster programme is now extended to 40 to 49s. On 16 to 17-year-olds and the announcement today of the second dose, confidence has grown with time that 2 doses of the Pfizer vaccine is the right choice for this age group. You've heard from Dr. Rain that confidence has also grown over safety, in particular the very low risks of suspected myocarditis compared with the long-term benefits of a life without COVID illness and COVID disruption. JCVI has used the data in an extra safety step of adding in that 12-week interval for the second dose in 16 to 17-year-olds without risk conditions. I've full confidence in both of the decisions that have been announced today. The UK expects it to have enough supplies of vaccine to implement these changes. The details of how to access the boosters for these extra 2 layers of protection will be announced in due course by the NHS. But in the meantime, I would say it is still a priority and a priority ordering for the booster doses. Age is still the biggest risk factor. The elderly, adults at risk, and health and social care workers remain the top priority for boosters. And we should never have a case where 40-year-olds without risk conditions are vaccinated en masse, whilst many 60 and 70-year-olds are waiting for their boosters. But the natural timing of when we implemented the initial programme should mean that in the main there is a natural ordering to the time at which somebody becomes eligible for booster at 6 months. So I don't expect this to be a significant problem. So the NHS is moving at real pace now, boosting 300 to 400,000 people per day, but all of this will still take some time to achieve. And I want to make another plea to people who have not been vaccinated or have only had 1 dose. It is now very clear indeed that 1 dose is not enough of any of the UK deployed vaccines, and that no doses at all massively increases the risk of hospitalisation. The latest UK Health Security Agency data show that for the age band 18 to 29, the rate of admission to hospital with COVID is 1.4 per 100,000 if double vaccinated, but 7.8 per 100,000 if unvaccinated, which is 5-fold higher. And for aged 30 to 39, those similar rates are 4.1 per 100,000 for the double vaccinated and 17.3 per 100,000 for the unvaccinated, which is 4 times higher. So just to finally summarise, the UK COVID programme is evolving as the data evolve. 2 further evolutionary steps are announced today. And this is how we go forwards. Wait for the data, move the dial. Wait again for more data, move the dial. Develop confidence and certainty with every step. People keep asking me about Christmas. I think for Christmas and the winter period, we can expect respiratory viruses to be around, and we are particularly concerned that flu will come back and add to our problems. And it could be quite a bumpy few months ahead. But everyone has a key role to play in achieving as safe and disruption-free a winter as possible. Wear face coverings in crowded places if it is practical to do so. Increase indoor ventilation whenever you can. Make sure you are vaccinated, and like any medicine, make sure you finish the course. And when you are called for your booster, please come forwards at pace so that we as a whole UK can get on and finish this job. Thank you very much. I'm now going to open this meeting for questions, the first of which I think is from Fergus Walsh at the BBC. Hi, Fergus.
Very much indeed. Can I ask, firstly, is it inevitable that we are heading towards third booster doses for adults of all ages? And also, is there an ethical question about giving booster doses in the UK and other richer nations while some poorer countries are struggling for first doses?
Wei Shen, would you like to take the technical question about consideration of boosters for lower ages than 40? And I will handle the other one.
Yes, thanks very much. So indeed, it may well be that adults who are under 40 years might require a booster dose or a third dose at some point. We don't know whether that is definitely the case yet. We are looking very closely at the data all the time, and should there be sufficient signal to warrant a third dose, so a booster dose for this age group, then certainly we will announce that and advise that accordingly. As regards the remit of JCVI, we are tasked obviously with advising what is best for the UK population, so I'll pass back to CCMO regarding the other part of your question.
Thanks, Fergus. So nobody working in public health would question for 1 second the ethos that until we're all safe from this virus, no one is fully safe. And there is, of course, a global public health concern about making sure that as many countries and as many people around the world have access to these vaccines. But equally, our job as advisors to the UK government is to give advice relevant to the UK, and that is what we do. We advise our ministers, and the UK has a massive programme of vaccine donation underway in parallel to our own vaccine programme, which is advised by JCVI. Next question is from Emily Morgan at ITV. Emily.
Hello, thank you very much. Given that only a third of the over 50s have come forward for their booster jab right now, do you really think that extending it to the over 40s is going to make any real significant difference to hospital admissions this winter?
Thanks for the question. Wei Shen, maybe you might start on talking about the rapidity of the response to the booster dose and help answer some of this question.
Thank you very much. I want to remind everyone that we know increasing age is related with increasing risk of severe illness. Increasing age is also related to the rate of waning of protection from the first 2 doses. And so the priority must be that we offer vaccination and we encourage vaccination in older people initially. The fact that a third of people who are over 50 are eligible suggests that we have still some way to go to encourage as many of the people who are already eligible for their booster dose to be vaccinated so that they can have the maximum protection for themselves. By extending the booster program to 40 to 49-year-olds, we're not looking just to this winter, but also looking to the longer-term protection, because there may well be evidence to suggest in future that the third booster dose pushes up the immune response and pushes out the immune response so that it lasts for much longer. And when I talk about much longer, we're hoping that the third dose, the booster dose, will mean that protection does not wane within 6 months or just after 6 months, as we're estimating now, but may be pushed out to much, much longer than that, so many more months. So it's not a short-term view. This is a long-term program. We're looking to the health of the nation, not just this Christmas, but maybe even up to next Christmas.
So, Emily, I think what we're saying is that we are trying to future-proof the COVID-19 vaccine program through the advice of JCVI. We're trying to future-proof the UK and its efficient functioning in the future. On the timing, you're right, there just isn't a second to waste now, and it's really important that we keep the clinics running at full capacity, all hands to the pump, and it's really important that the moment patients are notified that they are eligible for their booster, that they make whatever arrangements are necessary to get themselves a slot booked for vaccination as soon as possible. I'm turning now to Ashish Joshi at Sky.
Good morning. Thank you, Professor Van Tam. I was just really struck by a phrase you used just at the end. You said we should take our medicine and finish the job. Do you see the finishing line in sight? And what would it take for you to think the job has been finished?
I think that we are in for some potentially difficult months over the winter. We're at a very unpredictable point in the epidemiology. The modelling is getting more difficult to give us any very clear sense of whether things will turn up or turn down in the next few months. So I regard it as still a time of great delicacy and quite a bit of near-term danger. Do I personally frame that if our booster programme goes well and vaccine uptake remains high, that we will be in a much set of calmer waters by the middle of spring? Then I think I do. But this virus is unpredictable. We are still really very early on after it emerged in humans, and there are still many more lessons to learn, and we have to be constantly vigilant for the concern about a variant that might give us more of a problem than we currently have. So lots to play for still, not a time to relax, but I do see, once the spring gets here, hopefully some calmer waters ahead. Laura Donnelly at the Telegraph.
Hi. We've been told that the definition of fully vaxxed could in future include boosters. I wanted to ask when that's likely to happen for those in the over 50 category and what that could mean for travel. A question for Professor Van Tam. And just one more practical question in terms of the timing of the booster rollout. As I understand it, at the moment we've had about 12 million people have had booster jabs, and we've got about 32 million eligible by Christmas. You've just announced another 8 million people in their 40s will be eligible. Given all those numbers and the numbers that we've done so far, being much smaller than that, what would you expect to happen by Christmas if the vast majority of those eligible hadn't been vaccinated? Would you expect the government to have to consider other measures?
Laura, your link dropped out to me, so I didn't catch your first question properly. Could you repeat it, please?
Sure. Yeah, we've been told that the definition of fully vaccinated could in future include boosters, that, at the moment to get a COVID passport, a vaccine passport, is two jabs, and that in future that could extend to 3. I wanted to ask when that's likely to happen for those that are eligible at the moment, and what that could mean for travel.
Right, so the questions about changes to certification and thinking about boosters as part of that it is a matter that ministers decide, and if you'll forgive me, I will stick to the science on that. So it is just a science fact that we are seeing waning of the primary course, and that means that it is over time your protection against infection particularly begins to decline without further reinforcing vaccine doses, which we call boosters. Now, there is therefore a kind of logical point at which you would say to yourself, well, what does certification mean any longer if it is, I'm making up the figures now, 2 years since I had my primary course of vaccination? What does that actually mean in public health terms? And it's our job to present the science to ministers on that. The other thing I would say is that, I don't know, and, it's a very complex situation around the world, how different countries are viewing certification and whether certification will or will not be here a year from now, for example. I just don't think we can look that far into the future. But I can say on the science, there will come a point when what you had and when you had your primary course of immunisation may be less important than when you were last vaccinated. But that's all I can really say at this point. I don't know, Wei Shen, if there's anything you would particularly want to add on the kind of on the vaccinology in this area.
I don't think so. You've said most of what can be said. We certainly can't advise on what vaccine certification should look like, and that does involve both the UK and other countries, so it is more complicated. In terms of the science, whilst there is waning from the first 2 doses as we see it now, it is by no means the case that protection against severe disease wanes to the extent that there is no protection at all after the first 2 doses. It's just dropping, but not dropping to 0. So somebody who is vaccinated is still better protected than somebody who has never been vaccinated. At least that's the case for now.
Laura, you very sneakily snuck in a second question, which of course I've now gone and forgotten. So if you could repeat that one as well, please.
Yeah, sure. It's the numbers, really. So far, about 12 million people have had boosters, but about 32 million, I think, as of today, would be eligible by Christmas. Now you've announced another 8 million. What I'm asking is, if you can't get through all the bulk of those people by Christmas, are there any other measures that the government would have to consider?
So we know already that, as Wei Shen has said, that 2 doses of vaccine as part of the primary course very dramatically reduces the chances of hospitalisation and death. But let's focus on hospitalisations for a moment. So that's already very dramatically reduced in the UK, and you can see that through the kind of freedoms we've allowed. I've tried to do my best to extrapolate from the Israeli data this morning that extra booster dose has a massive additional impact in reducing hospitalisations. If we don't proceed at the right pace and we don't proceed in terms of people accepting the vaccine, then there will be more hospital admissions than there would otherwise have been. But I think you're kind of hinting at extra measures and Plan B, and I'm not in a position to judge that at the moment. Sam Blanchard at The Sun.
Thank you. I just wonder if you can say anything about if we've seen an impact of the booster rollout on the statistics at the moment, and would you have expected to see more cases, deaths and people in hospital now if we hadn't started the booster rollout?
So undoubtedly I would expect by now to have seen more in the way of hospitalisations and deaths in those very older groups in whom we started the booster programme earliest if we had not started it, because the evidence suggests that the antibody response and the protection pick up very rapidly after a booster, much more rapidly than after the initial primary immunisation course. But we don't yet have any signal from the UK Health Security Agency over our picture and our ability to assess the impact of boosters on hospitalisations and deaths. There is absolutely an analytical plan to do that and to get those data. But as you know, infections come before hospitalizations, sometimes a couple of weeks before with this illness. And those kind of data are also slightly more difficult to assemble. So please just give us a little bit more time, a few more weeks, and then I'm very confident that we're going to see a signal that is, I would say, broadly very similar to the Israeli signal. Eleanor Hayward, our last question today from the Mail.
Just on the issue of vaccination for children, uptake rates in the UK are very low at the minute compared to a lot of other Western European nations. How would you like to see this addressed? And do you worry about the impact low uptake could have over Christmas when you've got children mixing with elderly grandparents and things like that?
Wei Shen, would you like to start on that one?
Yes, and in fact I might bring in MHRA on this, because it may well be that there has been some reluctance to have a first dose of vaccine in 16 to 17-year-olds because of concerns around safety. But as we've heard earlier on, actually the data are now firming up such that it is looking much safer than was feared initially. So my message to people is that we are more confident about the safety of doses in 16 to 17-year-olds, and we're more confident about the benefits to 16 and 17-year-olds. So I would urge any 16 to 17-year-old who hasn't had any vaccine dose to certainly consider having at least the first dose, and in due course think about also having the second dose. I don't know whether you want to add anything.
That's absolutely right, Wei Shen. As the data have accrued, we've become more and more reassured that the safety picture in young people and children, teenagers, is just what we've seen in the older population, and no difference in terms of the small, very small risk of heart inflammation between the first dose and the second dose. So our message today is definitely come forward for your second dose.
Thanks, June. Thanks, Wei Shen. And I agree. I don't think, this is something to fret about. I think it just becomes clearer over time that everybody is more confident in the value of vaccination and in the very reassuring safety data that MHRA continue to look at on a daily basis. And, parents and children must decide for themselves, and we should allow them the time and the space and give them the highest quality information so that they can make those decisions in their own time. Thank you very much indeed for your questions today, and I now call this press briefing closed. Thank you.